So I saw all the conferences that we saw in the morning and now, and my job will actually be to summarize everything that we have seen. And for that, first I'd like to thank for this very kind invitation, the second time that I'm here with Professor Adel and Muhammad and the people from Orto House also, Perihan and Agar. Very nice people that I was very lucky to meet in Munich, in Germany in 2020. And that's my second time here. Thanks again, guys. You're very kind. You feel really, you are really feeling, make us feel welcome here. So those are my disclosure. So to understand where we are right now, we have to understand where do we come from. And learning history is something that my professor Osvan Drelek, a great friend, have taught me for the last 30 years. For us to understand where we are and where we are going, we have to understand where we come from. So the first shoulder arthroplasty is credited to Julius Emil Penn in 1893. It was removed at 3 years after for an infection. But in fact, that was first done by Themistocles Gluck. He performed ivory, knee, shoulder, ankle arthroplasties in animals, and then he tried in human beings. So he was the first to replace any joint, but historically everyone's credit Julius Emil Penn. But the greatest revolution, there's a lot of things that happened in between this area, was with Neer. His system in 1951 changed completely the way that we see shoulder arthroplasty right now. Then we come to the modern shoulder arthroplasty with his system as well in 1974, adding a glenoid and talking a little bit more about different sizes. So we come for the first generation monoblock prosthesis, and we had issues. The fact is that it failed to restore real anatomy. Then we get to the second generation prosthesis, where comes the modular. It could restore soft tissue balance and some anatomy. But only when we got to the third and fourth generation prosthesis, we could really play around with humeral head diameter, humeral head thickness, head neck angle, retroversion, and try to really restore the real anatomy. And I was telling Dr. Osvan Drelek yesterday, my friend, that we learned during our whole life that we should restore anatomy. But funny that now shoulder surgeons do some procedures that completely distort anatomy, like the reverse or the Larrage. So we should try to restore anatomy, but we have to remember that our goal is to give life quality for the people who search for us. And if we restore anatomy, but the restoration of anatomy don't give the best results, we have to really think what we are doing. And that happened over time. So the issue was not very easy to do the glenoid part. When we say about, well, there is like some meta-analysis showing that those 10,000 cases were perfect or not perfect, we have to remember that most of those were evaluated by masters, by people who publish articles. They are not the real population. They are not the guy working in small hospitals all around. So we have to always think about doing something that everyone can do, so we can help the population. And doing a good glenoid, do exposure of the glenoid was something always very hard. So we came for the glenoid development with many different retractors that could expose it better. So then come Pogramon in 1985, and I have to remember that he was not the first one who tried to reverse the joint. Lippenkessel has also a system that tried to reverse, but it didn't work. But the fact is that with his system, he medialized the center of the glenoid, and then he could practically say that we don't need the cuff anymore. Now this is changing because we're trying to do even reverse preserving the cuff. But at that point, we were dealing with situations that, well, what's going to happen if the cuff fails? If you don't have a cuff, you have a rocking horse effect, the glenoid is going to go loose, and then we're going to have a problem. So Pogramon appeared with this reverse system. And then the reverse began to get better and better with different studies showing what would be better. If we have to make it very central, if you have to lateralize, if we should make a better deltoid wrapping, which high, and then we begin to see all based by the European group that have shown us notching and how could we avoid the notching, what's the significance of the notching. So the systems have over time got better. And now we have a bunch of different designs. We have still the delta extend, the Zimmer biomat, inverse, many different from R-Trax, the right ascend, the DJO, Marx Franco DJO, who really lateralize very much the Lima system, the Exatec system with the navigation. So we have a lot of available systems now. And the surgeon can be, of course, he tries many times this or that system to realize which system will work better in his hand, which better outcomes will he have. We have a lot of design improvements after the century, not only in the humeral area, but also in the glenoid area. And using, I have a lot of experience with resurface. I did resurface for many, many years, trying to understand or to think that it will be better to change a resurface in the future for any kind of total anatomic or reverse. But in fact, it's a difficult procedure, so the reverse was almost the substitute for this stemless system here, where we could see in the left, where we don't have to resurface, we can use the anatomic, we can use a glenoid, and then we come to talk about technology that you have seen in the last 4 or 5 situations, a lot of technology. But can we still do our procedure without technology? Yes, we can. So many times we go to countries like even Egypt or Brazil and we present like flying glenoids and UFOs and things that are very nice. And those countries won't have that. So we have to teach them and to tell them about what is reproducible so they can also do things here. And we still have a lot of nice things besides technology. Technology should keep on going, of course, and I'm going to talk about a little bit about AI, artificial intelligence very soon, but we still can do everything without technology. So that's the growth, and as was shown before, reverse has taken the space, has taken the room for many, many different situations, including fractures, as was shown in the prior presentation. And for the glenoid placement, it's good that Angelo has shown us details of that. We have the PSI, we have the navigation, the GPS navigation that can be used. It's not complicated to use, and the fact is the GPS has data, has more than 10,000 cases done. There is a huge database that shows the best way to do this, and we really can see it online. And this slide was shown before and shows that navigations make a more precise finding of the center of the glenoid. Is that necessary for all replacements we're going to do? Probably not. I asked Dr. Zuckerman what's the difference between using or not. He said, well, after doing more than 2,000 procedures without navigation, now I consider myself a better surgeon. And that was the same answer that Dr. Florian Drum from Freiburg in Germany has given me. But in fact, in my practice, I feel that you can use navigation. It's nice to use navigation. It's more precise. But in most cases, it's probably, if you understand, like Angelo has taught me now in the coffee shop, if you really understand what's going on, all together, if you imagine in most of the cases, it won't have a huge glenoid erosion. You will see that you can do it a very precise finding of the center of rotation without that. Of course, there are cases where the glenoid is very bad and very thin, and it's going to be very helpful to use technology and navigation. There's a lot of studies out there. This is an important study. It's a comparative study showing a comparison between navigation and freehand, and shows that it's more accurate in placement of the central cage, angulation, and screw length. This was shown now, the app, that's the app that we can use to find and to plan our procedure. This app can be used when you do navigation, but it also can be used if you download your CT scan and you can alone design the Friedman's line and plan every case you need, even if you're not going to navigate. You can use that. You can see where the glenoid is going to be. You can plan that, and during the surgery also you're going to see that, and you can change that. So planning and navigation is the next step. I mean, you can plan, you can use the app, and now you can also navigate with that. But you can plan, you can use an app, not only this app, but other apps down, and during procedure, use that help. Navigation is the next step, and there is this GPS navigation, more than 15,000 knees and shoulders, showing a great database showing where we can go, showing all the pitfalls. And also now, the next star, which is from a Swiss company that was just published, this article some 1 month ago by Zumstein and Professor Alexander Lederman, showing that we can use navigation and augmented reality to increase your accuracy, increase your precision on that. The new app has the humoral components to be planned, but not to navigate. Have shown that it's not necessary to navigate, but you can plan your cuts, you can plan your size, you can plan what you're going to use, and also plan and evaluate the joint, the rep, the lateral offsets, notching, and all things can be planned before. Let's just talk in this last 2-3 minutes about artificial intelligence. I was very curious. I mean, I began to read a little bit about Web 4.0 to Web 5.0. What's that? You know, sometimes we doctors study only cuffs and fractures, and we forget to see what's going down. So my friend Bruno Gobato from Brazil, who is a guy who studies a lot of AI, explained me a very simple way to understand what is artificial intelligence. Because it was how the machine knows. We have to teach the machines. We have to show the machine. The machine is not going to be learning everything by its own. And it's like we, as babies. So how do we get to know that this guy here is a cat and the other guy there is a tiger? We don't, when we were born, we didn't know that. If someone has taught us in a different word that that was a tiger and that was a cat, probably we would have think that that's a tiger. But our brain has this information. So we have been taught for many times in the school or in the streets, oh, look, like this little kitty. Or you go to school, that's a cat. Or in different languages, a sha or a katze or whatever you think. So we learn that. And that's what we're going to have to do with the machine, to teach him. So what is about artificial intelligence that we see every day? It's like Netflix, for example. You begin to see a series about crime, and in the other day there's like tons of crime scenes. There's, oh, that's you're gonna like. That's based on what information they have. If you show to a radiologist to show what is a lung tumor or a small tumor, and you show this like 20,000 times for this machine is gonna know. And whenever he sees a small lung tumor, he knows already because we thought that. And that's artificial intelligence. And what we are right now in terms of this thing, we have already in the app, in the Exatech app, the Predict Plus, which is a tool that has been used for the last 1 or 2 years, where there is a database of information for more than 15,000 cases, where we can add information about the patient. Is he a smoker? Is a cuff tail arthroplasty? How is his motion before the procedure? How is his abduction? How is his external rotation? And then with all this information, we put an input for every specific patient, and the computer instantaneously show what we can expect for that. So we can say, you know, with this kind of procedure, with this kind of pre-op motion, you will probably have this kind of post-op motion, this kind of relief. And of course, as we are doing this for the last 2 or 3 years, the prediction goes until 7-8 years, but it's not accuracy because we haven't seen what's going to happen in all those years. So we're using that for everything in life. And at this point, we're using that for precision in terms of predicting outcomes, but not in terms of really precision, as I believe it can be the future. So that's the Predict Plus. You see, we do a lot of information, the VAS score, global shoulder function, constant score, ACEs, and then we have this prediction. So where are we going from now? I believe that that's where we are right now. If you summarize everything that the other speakers have shown us about technology, about indications, about the fact, for example, it's very nice that Osvandre has shown us that conservative treatment is still, remember, because many times we're talking about surgery and people forget that many humeral fractures can be treated without surgery. So there's a lot of new information. So will reverse versus TSA achieve a balance and standard indications? Because what I believe now, what I see now is that anatomic total shoulder is almost gone. Most of the surgeons say, well, I will do a reverse. And I believe there is still room for anatomical reverse. There are still indications for hemi and resurfacing models. Yeah, I still believe there is still room. Not like it used to be before. I need like 10 seconds. Just 10 seconds. Will computer planning and artificial intelligence improve prediction and surgical precision, and that will positively affect our outcomes? We are not here to play God. I mean, it's very nice to see a shoulder flying in the room, or if you can do a procedure, and that's going to be together with someone in the other side of the world. But that a factual outcome that will make us better outcomes and better results. And always that what I've learned, if we don't look to the past, we won't be able to design a better future. A lot of things that Codman taught us back in the 1930s are still done today. We stopped doing and we're doing today. I can just remember one example. The Latarjet procedure in the 80s were demonized. They say never do a Latarjet anymore because there's like a ton of complications, and probably Latarjet is one of the most common surgeries nowadays. So look to the back, feel the present, and think about the future. Thank you very much.